This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Okay, thanks everybody. So David, Okay, might just grab a seat. Thanks, everybody. So, Justine. Thanks, everybody. It's nice to see you all catching up with people. That's great. So, we're already a little bit behind, so that's partially my fault, so I apologise, but thanks very much for coming back. Our next speaker is Dr. Chris Calder, who's a good friend and mentor of mine for many years now. So Chris is infectious disease physician and microbiologist was our director at Prince Charles, is now our statewide TB lead and director, and also director of the Mycobacterial Reference Laboratory. And Chris is on the WHO PK PD committee and has many roles in there, WHO as a consultant, as well as being on NTAP, recent chair. So Chris is going to talk about some of the, obviously, the susceptibility aspects. So thanks, Chris.
Thanks, Andrew, and thanks both to you and Rachel for some really great talks to start off today's symposium sessions. I'm going to talk about drug susceptibility testing for TB and non-tuberculous mycobacteria, and I'm largely going to talk about what we actually do. We're a WHO associated laboratory. We largely follow WHO methods or CLSI standards. So I'm going to tell you what we do, and perhaps at the end what we could do. Sorry, how about that? Okay, so most of you would know that we categorise resistance in tuberculosis, and broadly within the drug-resistant TB categorisation, the one that has the most attention is MDR, multi-drug resistant TB, resistance to rifampicin and isoniazid. But in many parts of the world, the best, or sometimes the only drug that can be tested is rifampicin through molecular methods. And largely WHO recommendations on treatment apply to rifampicin-resistant TB as much as it does to MDR TB. So, multi-drug resistant TB, we know, is a major public health issue. There's about 500,000 cases occurring each year, and the frequency and incidence of these notifications is increasing. If we look to our immediate north, Papua New Guinea has a significant burden of MDR TB, as do a number of other countries in Asia, Sub-Saharan Africa, and the countries of the former Soviet Union. In this WHO map, all in the darker shades. Australia, we sit about less than 2% of our TB notifications as being MDR TB. Now, on a global sense, how well do we treat multi-drug resistant TB? WHO figures, this is up to 2016, the answer is not all that well. Less than 60% success rate, which is the green bar, for treatment of MDR TB. So, if resistance is a problem, how do we detect it? Now, traditionally, we're talking about phenotypic drug susceptibility testing of M. tuberculosis, and there the premise was that you test at a critical concentration, so a single concentration which will be able to determine separate strains on a 95% or greater probability that they were, if you take strains that were naive to previous treatment, but on 95% or more, they will be susceptible to this critical concentration. And if you take strains from patients who have treatment experience and failed treatment, you'd expect to see that there will be resistance. And that was sort of the traditional basis for drug susceptibility testing. It was also determined that if there was 1% or more of the population of the cells being tested resistant, then you'd likely have treatment failure. And this is the basis of the proportion method of drug susceptibility. So, unlike E. coli, which has a sort of an in-laboratory generation time of 15 to 20 minutes, TB is much slower. So it takes about 24 hours or so to multiply. And that translates for a sort of a median time to detection for diagnosis, even in liquid culture systems, even for smear positive samples, of about 8 days. Longer if it's smear negative. And the basis of the proportion method is testing it in solid media at 2 different concentrations and comparing those concentrations, and the 2 concentrations are 1 and 100 dilution, and so you can make an assessment about whether 1% of the population or more is resistant. In more modern times, and all the Australian and New Zealand mycobacterial reference laboratories use liquid culture. So we use the Bactec Midget 960 system to do a modified proportion method. And so if we're only testing at 1 critical concentration, how we get to those critical concentrations and what they actually are has a lot of importance. Periodically, the WHO convenes an expert panel to assess these critical concentrations, and on the slide are the current recommendations for the first-line drugs. And you can see that they're quite media dependent. If you look at rifampicin, your critical concentration is 40 micrograms per mil of rifampicin in LJ media, but only 1.0 micrograms per mil in midget. If you look at ethambutol, the concentrations are different for every media that's used, including 7H10 and 7H11 Middlebrook agars. The other thing is some of these critical concentrations may not be at the correct value, and there is an expert group meeting in Geneva at the moment looking at first-line drug critical concentrations and whether they're in fact correct. We may see interlaboratory variation, and that's been well documented by these proficiency test rounds that go to the supranational reference laboratories, where for some agents such as streptomycin and ethambutol, we do see significant interlaboratory variation. Pyrazinamide susceptibility, so a first-line drug, but it's only sort of endorsed for treatment through the midget system, and it can be technically demanding. If the inoculum's a bit high, false resistance is a common finding. You've got to test at an acid pH, whereas more neutral pH for the other agents. And if you look at all this fine print, which we won't be able to read, but I've blown up this line, and they say, well, look, ethambutol is so inconsistent, don't even test it. Now, I don't know if it's exactly true, but it gives you an idea of the confidence in ethambutol. Many of you are familiar that the WHO has recently revised its guidelines for the treatment of drug-resistant tuberculosis, and we now see the appearance of medication which had previously been either not in the guidelines or softly endorsed through demonstration or phase 2 or 3 studies. So we now see the predominance for drug-resistant TB treatment of not only fluoroquinolones, but bedaquiline, linezolid, clofazimine, and in the add-on group we see the prominence of delaminid. So these are new drugs. They've been introduced as a global recommendation, but can the labs actually test susceptibility to these agents? In 2017 there was 2 groups that met looking at both revision of critical concentrations for the new drugs and also a new manual for how to technically do the drug susceptibility testing. The critical concentration group, which was all published, both published in 2018, the critical concentration group took the opportunity to perhaps be more definite about what the critical concentration is, and it defined as the lowest concentration that will inhibit the growth of 99% of phenotypically wild-type strains of M. tuberculosis. If you think about that, brings it in line with really what UCAST and CLSI would say an ECOF is. The critical breakpoint was a new concept for TB drug susceptibility testing, in that it defined a concentration above the critical concentration where essentially low-level resistance could be overcome by using a higher dose. And so a new concept for TB medicine of the clinical breakpoint. This is some data from the UCAST website. It's looking at delaminid MICs against TB, and you can see here that you can, looking at the MICs, and that the upper end of the phenotypic wild-type distribution would be 0.06, and these higher concentration inhibited strains would be non-wild-type strains. And so that would make you think that the ECOF, and therefore the critical concentration for delaminid as a new agent, should be about 0.06. And in fact, that's what the critical concentration group concluded, although on this table of new critical concentrations, anything in red is at this stage considered interim. But it gave us a critical and a clinical breakpoint for moxifloxacin, susceptibility critical concentrations for bedaquiline, for delaminid, and also clofazimine. But note, not all test media are represented, and really because the studies weren't done. If the studies were done in midget, you could use that data. But if there's no studies in LJ, well, there's nothing to base a conclusion on. There are also other considerations as we move to introduce these new DST methods, or at least new agents. And bear in mind, there's not many countries in the world who actually have the new agents available on a routine basis for DST. So when you're introducing these things, you've got to do an in-lab validation study. So you can't just make up the concentrations and start testing. You have to source control organisms to do your validation study, and until recently that's been difficult. You have issues regarding regular QC, but also external QA. A well-curated set of organisms is sent around to the supranational reference laboratories and selected national reference laboratories for testing, but that proficiency panel doesn't go to all countries and certainly not to all labs. So with phenotypic drug susceptibility testing, we're aiming to separate phenotypic wild-type and phenotypic non-wild-type strains, hopefully with clinical significance. But as I've pointed out, the growth is slow. It does have the advantage of that you don't need to know the method or the mechanism, the molecular basis for the resistance. You're just testing against a concentration. But nonetheless, you may not detect all types of resistance with phenotypic methods which will predict treatment failure, and there is a lot of technical demanding stuff in how you do it. Genotypic resistance, on the other hand, is rapid, and it can separate wild type and non-wild type on a genetic basis. Depending on the method you use, you may not detect all the relevant mutations, and maybe not all relevant mutations are known with respect to certain particular lesser used drugs. And so results may vary on different technical factors: the DNA prep, issues of cross-contamination, quality control for your sequencing techniques. But we do know a lot about, and increasingly so, about the molecular methods of resistance for Mycobacterium tuberculosis, and I won't go through every gene that's listed on these slides, but if you get copies, you can use that as a quick reference. A number of agents have commercial methods with which to detect resistance, and perhaps the best known would be the Gene Xpert, the Gene Xpert Ultra, the line probe assays, the MTB-DR+, and just very recently a more portable system called the TRUNCATE system. And so we can easily, with commercial methods, in most cases detect rifampicin resistance, isoniazid resistance, and for the second line drugs, using the second line Hain strip, the gyrA and gyrB mutations that characterise fluoroquinolone resistance. So the Gene Xpert over the last 9 years has been somewhat of a game changer in detection of resistance through large parts of the world. We use it here. It's used in the remotest parts of many villages in low and middle income countries. It's a cartridge-based system which uses real-time PCR technology to detect the presence of TB and the presence of rifampicin. Now, if you put Ultra after something, it must be better. Indeed, the Xpert Ultra is the latest incarnation of the Xpert MTB RIF assay, and it has been endorsed by the WHO as a substitute for the conventional G4 Xpert on the basis that it's more sensitive, particularly in smear-negative culture-positive cases. It's more sensitive in HIV-positive subjects. It seems much more sensitive for TB meningitis and for most forms of extrapulmonary TB. And from the 2017 initial endorsement, just in January of this year, there's been an expansion of those recommendations, as well as the endorsement of the alternate system made by MolBio, which is the TRUNCATE system for detecting rifampicin resistance and TB. Okay, so what's different about the Ultra? And I've just borrowed one of Sefid's summary slides here, but basically it's more sensitive because it's got more targets. It targets IS6110 and IS1081, and there are multiple copies of these gene targets as opposed to the single RPOB gene target of the conventional Xpert. It uses a melt curve methodology to look for mutations within the RPOB hotspot. It has a bigger reaction volume in the cartridge, and it's quicker. So roughly about an hour and you have your result. One thing to be aware of with the new Ultra assay is a category result called trace. So if the assay detects only one of those insertion sequences which are in multi-copy, it may not, if it's detected in low numbers, it won't have enough signal to detect the RPOB binding and do the melt curve analysis. So you get what's called a trace core. So it's positive at trace amounts, but the rifampicin result is indeterminate. And that sometimes confuses clinicians. What does that mean? Does that mean you're saying it's really resistant, but you don't want to say that? But it simply means you can't make a call. You can say that TB is likely there, and for an easily obtained specimen like a sputum, it should be repeated, because some of those trace calls will actually be true false positives, but many of them are actually true positives, and it's what largely but not exclusively gives the new Ultra assay greater sensitivity. Now, in a large multi-country demonstration study involving over 2,000 subjects, the sensitivity and specificity of this Ultra assay was looked at. The conventional Xpert only gave a sensitivity for detection in smear-negative culture-positive samples of 46%, but it was improved by 17% to 63% by the Ultra assay. And you can see that overall, if you look at all comers, the Xpert sensitivity 83% and the Ultra almost 90%. If you look at specificity, however, the Ultra is a little bit less specific. So why would this be so? And in the main, it's because of previous TB infection. So when they looked at their data according to past history of TB therapy, the blue line there is the Xpert Ultra, and the green or the red line is the Xpert conventional Xpert. And you can see that when someone's had TB within the last 2 years, there's quite a gap in specificity. And furthermore, it can take up to 10 years before that difference in specificity, before the impact of old TB leaving old DNA around no longer seems relevant. So the flow on from that, of course, is that neither test can be used as a test of efficacy of treatment. So these are diagnostic tests, but not tests for monitoring therapy. And you can see that there's a 5% drop if the patient had, in specificity, if the patient had any history of TB. The other WHO-endorsed method of genetic susceptibility testing for TB is the line probe assay. This is a PCR assay which hybridises particular gene targets, and you get a strip reading with relation to certain antimicrobials. And resistance is determined by either hybridisation to a specific mutation band. The absence of hybridisation to a wild type infers resistance, and if there's all wild type landing, then you've got no resistance. The Gene Xpert is a better test for determining rifampicin resistance because it's quicker, even though you can do the same thing with the first-line line probe. But the second-line line probe is very important with respect to getting patients onto treatment for MDR TB for the short course regimen. Because in the short course regimen, which is a combined oral IV regimen that goes for 9 to 11 months, one of the contraindications is resistance to either the injectable or, importantly, the fluoroquinolone. So using the line probe assay, you can quickly determine the second line probe assay whether there's fluoroquinolone or injectable resistance, and therefore the patient is not eligible for the shorter course MDR regimen. But not all mutations are created equal. And if you look at, for instance, the gyrA mutations, there are certain mutations such as the valine substitution of position 90, which gives low-level resistance. However, something that we would see commonly when we have these resistant strains, a glycine substitution of position 94, that gives high-level resistance. And so if you get these high-level resistance, you probably shouldn't use fluoroquinolones at all. But if you get the low-level resistance, you should do phenotypic drug susceptibility testing, looking at that clinical breakpoint for moxifloxacin, because it still may be able to be used in the regimen at a double dose. And of course, what's become routine for many jurisdictions, although sadly not my own at the current time, is routine whole genome sequencing of TB. And this allows rapid prediction of drug resistance as well as be able to identify clusters and transmission. And I'm not sure, we haven't had to devise a report yet, but what clinicians in other states are probably getting is a report outlining what the mutations are and what the inferred resistance is. Quickly move on to non-tuberculous mycobacteria, and Rachel's already told you much about the epidemiology of NTMs, but by far the most common one we get is Mycobacterium intracellulare. And we follow the standards of the CLSI, Clinical Laboratory Standards Institute, based in the US, in how to do susceptibility testing for NTM. And the reference method is the Broth microdilution, so a 96-well plate, which we obtain commercially, and it has set concentrations to obtain an MIC for the agents that are on the plate. So the question about rifabutin, rifabutin's not on the plate. But if you've got a big enough demand, one can go to the manufacturers of the sensitivity plate and customise your plate. And maybe if rifabutin's taking a bigger role for treatment of, say, M. abscessus, we could approach the manufacturers about an Australian customised plate. There are set criteria for interpreting the MICs into sensitive, intermediate and resistant, but note there is no breakpoint for tigecycline, which we've already heard is a very useful drug for M. abscessus. Generally, for rapidly growing mycobacteria, you incubate at a lower temperature, and for some slow-growing M. abscessus strains, you might have to observe the plate up to 14 days, but that's only useful for clarithromycin and amikacin because the others are unstable. I do want to talk quickly about the gene, if the timekeeper allows me. So we heard earlier that a functional gene encodes inducible macrolide resistance, and this is seen in most but not all strains of M. abscessus subspecies abscessus, particularly sequivars, the more common ones, 1, 6 and 7. It's almost universally seen in Blottii, but it can also be seen in other rapid growers, in particular M. fortunatum. And to detect this phenotypically, you must incubate the plates for 14 days. Constitutive resistance is a 23S mutation in the ribosomal DNA, and that will generally show resistance at day 3 to 5. Non-functional genes show clarithromycin or macrolide susceptibility, and this can be done with a single mutation in the ERM41 at position 28, and this is sequevar2 of subspecies abscessus, so they're susceptible to the macrolides. And we also see most notably non-functional genes in Mazilliense, but there are other species as well. If you actually, for us, we generally don't have the species when we set up the DST because we're trying to improve the turnaround time. But if you know the species, you can simply report at day 3 and 5 if you know the gene status without having to do the 14-day incubation. There are interpretive criteria which are relatively limited for MAC complex, but as Rachel mentioned, liposomal amphotericin as an inhaled product has its own category call for sensitive and resistant with a higher MIC than systemic amikacin. But for NTMs, there is a lack of standardisation for many drug-bug combinations. There's significant variability in wild-type susceptibility and lack of in vivo correlation with effectiveness, particularly at different sites of infection. However, if we can do broth microdilution for NTMs, why don't we do it for TB? In fact, Sensitita do make a myco-TB plate, just for out of interest, it's got rifabutin on it. But there's no interpretive criteria. Now, a study that's only just recently been reported goes a long way to giving us interpretive criteria. It's a study from South Africa. It looked at a variety of different lineages of TB, and it used whole genome sequencing to determine what was genetically wild type and what was genetically mutation type, and then it looked at the ECOFs at a variety of different percentages of ECOFs, but in particular at 99%. And based on their data, it would suggest that that we have some interpretive criteria for using broth microdilution for TB. However, while some of the new drugs such as linezolid and clofazimine were investigated, not all. But that is being addressed, and the Cryptic Consortium recently published on validation of a 14-drug microtiter plate. They got excellent results in the validation study amongst some reference centres looking at the difference between wild type and non-wild type and their MICs, and this plate does include delaminate, it does include bedaquiline. So, in summary, phenotypic DST for TB remains slow, and I didn't go into it, but it's actually quite expensive. There are new critical concentrations available for the new drugs, and they may be modified with time, but we've got a place to start. Increasingly, we're using rapid methods for rapid molecular methods for drug susceptibility, and these, in some cases, might outperform phenotypic methods. Whole genome sequencing is becoming routine, but still requires a culture. But watch this space. In 10 years' time, we probably won't be saying that. Broth microdilution might become the preferred method for TB, and it's currently the reference method for NTMs. We've explained about the and 23 molecular story, and however, at the moment, commercial rapid methods for DST and routine whole genome sequencing for DST purposes is largely unexplored for NTMs. So thanks.
Thanks, Chris. Any questions? So, Chris, from the WHO point of view, in terms of whole genome sequencing molecular methods for low and middle income countries, do you think that's likely to, obviously we've got Ultra and Xpert already, what do you think the future is for those countries?
Increasingly, countries which would be considered low and middle income countries are entering the genomic space. I think there is a multi-centre trial looking at that at the moment as an implementation. Some of the countries have done their work by sending the isolates away, but increasingly it's being done in country, and I think that's very likely the way that things will happen. I don't think it's a deal breaker that this technology is currently expensive. I think it will be adopted in many different settings.
Okay. Any other questions? Okay, well, thanks, Chris. So our next speaker is Dr. Markian Topkiani. So Markian is our most recent mycobacterial fellow in Brisbane. So we're very proud in Brisbane that we've had this mycobacterial fellowship position for 12 months. I think it's fairly unique in Australia. And we've had respiratory advanced trainees who have sort of finished their training and don't want to make a lot of money in sleep positions and they want to do something different, and they've done mycobacterial fellowship. And then Markian's been our first ID senior registrar to do it. So sort of been funded because there's a bit of a risk registry, if you like, at a national level, and it was felt there was a lack of knowledge of managing mycobacteria in the Australian workforce among the respiratory physicians, and that was part of how we got justification for funding it. So it's basically just a little plug here for the job, obviously. So it's and others Tim and Justine have done it, and we're very proud that we've got within 4 years, some really excellent clinicians who now have expertise in mycobacteria, and it's really turned things around in Queensland. So I've given Markian the difficult talk of talking about the new TB drugs, which all of us, most of us here are grappling with still. So Markian's finishing with his micro, 6 months, which I know every ID trainee struggles to get. So that's his doing when he's not here. Thanks, Markian.
Excellent. Sorry, if I'm working. Excellent. Thank you. Yeah, so Markian Platon, I have 2 first names. It's great. So I switch up between both of them. But yes, general medicine and infectious disease training. I don't have a lot of time, and so I thought these slides will be available. So I'll just try to talk them through pretty quickly. I can talk underwater, so we can go pretty fast with these things. Basically, I'm going to talk a bit about these new drugs, a little bit about the trials that lead them into clinical practice, and we'll go from there. So we know that TB is a huge global problem with the increase in morbidity and mortality, and more so now multi-drug resistant TB. In Australia, rates are low, but as Dr. Coulter said, that knocking on our doorstep are a lot of high-burden countries. Historically, the treatments have been really long, costly, toxic, leading to poor compliance and poor outcomes. So that's part of the reason why we need new drugs. We haven't had any new drugs for a long while, for nearly 40 years into this last 15 years. And ideally, we'd like these drugs to be, less toxic, more palatable, oral, if possible, with reduced drug-drug interactions, and accessible and affordable to all around the globe. So just a brief case. This is a case of a 31-year-old man that we saw last year from China. He was a meatworks worker. He had lumbar back pain for 3 months and fevers and night sweats. So constitutional symptoms. He had a CT of the spine, showed an L3 fracture and osteomyelitis, a biopsy cultured MTB, and he also had some meningeal enhancement on MRI identified with hearing loss and some scanty pulmonary involvement. He was found to be rifampicin resistant on GeneXpert, and a line probe assay also suggested aminoglycoside resistance. This was all confirmed on DST testing, and essentially he was changed from his amikacin to an all-oral regimen with bedaquiline, linezolid, moxifloxacin, clofazimine, and cycloserine. Now, prior to bedaquiline, these new agents being available, amikacin would not have been able to be used, and perhaps would have had to supplement with other secondary medications, perhaps without the benefit. So this is new. This is an all-oral regimen for a disseminated MDR TB, essentially. So the first drug, delaminid, it's in the nitroimidazole class. It's a prodrug that gets activated by a nitroreductase. It inhibits cell wall methoxymycolic and ketomycolic acids through an intermediate metabolite. Its major side effects with most of our drugs are QTc prolongation and gastrointestinal, but for the most part, it's pretty well tolerated. It's indicated for 6 months of treatment in MDR and pre-XDR and XDR TB, and it's not allowed at the moment in those under 3 years of age and in pregnancy. So early phase 2A studies were looking at sort of a small set of patients comparing the different drug doses in fully sensitive pulmonary TB compared to the standard 4-drug therapy. And what they're looking at is a reduction in colony-forming units as a marker of early bactericidal activity. And they found that the dose of 200 and 300 milligrams had the greatest effect over that first 14 days, and that delaminid exposure was less than dose proportional, plateauing at 300 milligrams. A larger study, the phase 2B study, looking at 161 patients and comparing 100 milligrams twice a day versus 200 milligrams twice a day for 2 months versus placebo with the optimized background regimen, looking again at sputum culture conversion over a 2-month period, And here they found that there was a 50% increase in sputum culture conversion with 100 milligram dosing, and no added benefit with the 200 milligram dosing, but the added cost of an increase in QTC prolongation. The other remaining side effects were similar between groups, and there were no adverse outcomes with the QTC prolongation. Unfortunately, nearly all the patients were HIV negative. But at this stage, it was conditionally approved for use in November 2013. A subset of those patients, around 87.5%, were also recruited for an open-label 6-month additional period of delaminid in this non-controlled study. And then also a component of that was an observational study, a long-term 24-month follow-up to see favorable or unfavorable outcomes. And what they found is those who had 6 months or more of delaminid actually did better and had a favorable outcome, and that there was a long-term reduced mortality in the 6-month or plus arm. Now, a phase 3 multi-center randomized controlled trial most recently didn't quite show the same thing, but this was a multi-site, multi-country study, again looking time to sputum culture conversion over 6 months with the delaminid with a regimen of 100 milligrams twice a day and then 200 milligrams daily for 4 months versus placebo, in addition to the optimal background regimen. There was no difference in time to sputum culture conversion, and there's no real difference in treatment success or mortality. That said, thoughts for this were that perhaps there are more severe cases in the delaminid arm with cavitary disease, and that those who were in the placebo group actually got really good care. In fact, their rates of success were greater than baseline on the background regimen. So perhaps they had really good effective care, and perhaps that's why there was no significant difference. But perhaps keeping delaminid available. Now, delaminid is increases its bioavailability increases significantly with food. It's mostly protein bound, and metabolism is thought to be through multiple pathways with minimal cytochrome P450 involvement. It has about 5 major metabolites, but the predominant one is M1, and its excretion is predominantly in stool. Side effects I mentioned is predominantly QTC prolongation, and this is increased with that M1 metabolite. And with respect to CSF penetration, the data is limited. Animal studies suggest it does get into brain parenchyma compared to plasma, but only limited levels in the CSF. So it's conditionally it's used now at the moment, as per the WHO, to be included where you cannot create a regimen from groups A or B medications to complete your regimen. But it may be useful in those who've got pre-existing liver dysfunction, those where there's concern for drug-drug interaction, as it has few, especially those on antiretrovirals, and those who may have had prior bedaquiline exposure. So moving on to bedaquiline quickly, it's a new class of antibiotics, a diaeroquinolone. It inhibits bacterial ATP synthase, bactericidal and sterilizing effect. It's to be taken with fatty food orally, and initially there's a loading dose followed by maintenance thrice weekly dosing. It again has QTC prolongation and hepatitis as its major side effects, and not included in pregnancy or those younger than 6. Initially approved in 2012, and now is wholly endorsed as per guidelines we'll discuss later on, in both short and long course. So again, phase 2B randomized trial looking at a small cohort of patients with MDR pulmonary TB with bedaquiline for 8 weeks compared to placebo plus the optimal background regimen. Unfortunately, nearly 50% of these patients were not had to be removed from the trial, but the limited numbers did show that there was increased culture negativity at 24 weeks, or when patients discontinued the bedaquiline, and increased time to sputum culture conversion and overall conversion with actual similar adverse effects between the groups. A larger trial, a phase 2B trial of 160 patients now comparing bedaquiline again for 6 months versus placebo on that background regimen, now did show significant reduced mean time to culture conversion and an increased culture conversion at that 6-month mark, as well as increased cure at 120 weeks compared to placebo. Again, adverse events were similar between the groups. Deaths initially were more in the bedaquiline group, but on further analysis were thought not to be related to the bedaquiline. A follow-on open-label single-arm trial looking at bedaquiline now for 6 months with the background regimen in those who had treatment naive, but also previously treated MDR-TB, including pre-XDR and XDR, looking at overall culture conversion at 120 weeks, and showed quite reasonable results even in the XDR patients. included into a two-stage trial known as the STREAM trial. Bedaclin's been put into two different regimens. The first stage is that of comparing the Bangladesh short course regimen with the conventional long course regimen, and results in April of last year suggest that the short course is non-inferior. The stage 2 now includes Bedaquiline in a 9-month all-oral regimen with Bedaquiline for 9 months, and a short course regimen with 6 months of Bedaquiline with 2 months of an injectable agent. So those results should be out later at the end of the year or early 2021. Now, again, Bedacline's absolute bioavailability is unclear. It's highly protein bound, and it's lipophilic, and it accumulates in tissues and then slowly releases from them. It does like to distribute in macrophage-rich tissues, but not so much in other fluids such as blood or bodily fluids like CSF, where it's not found to be very detectable even after 6 weeks of dosing, and also limited detection even in inflamed meninges. It's predominantly metabolized through hepatic pathways with 8 metabolites. The most significant one is the N2, and it's 4 to 6 times less active, but unfortunately has increased QTc toxicity or prolongation. It's not really an inhibitor or inducer of major CYP enzymes, but can have interactions with certain medications like rifampicin, which can reduce its levels, and which may be important if it is used in treatment of NTM infections down the track, and interaction with certain antiretrovirals. It was initially endorsed in 2013 and very wholly endorsed in 2019 in both a short and long course regimens. Now, lastly, Protominid is our last drug, and this is probably one that's the newest kid on the block, so to speak. Again, it's a nitroimidazole class, and it was created by the nonprofit TB Alliance Clinical Development Group. Now, the prefix Prito is a nod to where it was developed in Pretoria, South Africa, and it too is a prodrug that's been activated by the TB organism through a nitroreductase. It does have bactericidal and sterilizing effect through nitric oxide release, and its activity has been seen against most drug-resistant isolates, and also has the added benefit of being with minimal activity against gram-positive and gram-negative bacilli. Again, a daily dose of 200 milligrams with fatty food, and the side effects, as we see with most of these medications, are QTc rise, hepatotoxicity, and myelosuppression. Now, there has been some concern over infertility in males with testicular atrophy in rats, and so that'll need to be monitored clinically. And there is this transient rise in creatinine with use thought to be blockade of proximal tubule excretion in the kidney. Now, there was a limited population pathway rapid approval through the FDA in August 2019 based on a trial I'll discuss in a moment, and this is for Bedaquiline use, to be used with Bedaquiline and linezolid for the BPAL regimen for SBR and intolerant non-responsive pulmonary TB. So, proof of concept trial, after being found to be safe in healthy subjects, was out of 65 patients with smear-positive, drug-sensitive TB, various different doses compared to the standard 4-drug regimen. Now, the primary endpoint was mean rate of change in log colony-forming units in sputa, and what they found is the dose, there was equivalent fall in all 4 doses, with actually the maximal efficacy in the lowest dose of 200 milligrams, and peak serum concentrations at 1 gram. A follow-on phase 2 open-label, partly randomized control trial. Important to mention, really just comparing Protominid dosing with other agents of interest, such as moxifloxacin and pyrazinamide in drug-sensitive TB. But there was a non-randomized cohort of 26 patients with MDR TB, and this is probably one of the earlier studies looking at Protominid in drug-resistant TB, and that's why I'm mentioning it. Although most of the patients were excluded in that 26 patients, so around 15 were removed, so only 11, and only 7 actually completed the trial. With respect to the drug-sensitive component, there was actually shown to be quite good efficacy at reducing with bactericidal activity and reduction of colony-forming units in the sputa compared to standard 4-drug regimen, and also some activity with nearly same rates with those 7 patients who completed that regimen with Protominid, moxifloxacin, and pyrazinamide. Now, a similar study with a different combination now, including Bedaquiline into this regimen, again looking at fully sensitive smear-positive patients. But this group also had a non-randomized portion of 60 patients this time, of which 56 of them completed the trial. And this was for rifampicin-resistant TB, of which nearly 90% also had isoniazid resistance. So essentially MDR-TB cohort. And they were randomized to have bedaquiline at a daily dose of 200 milligrams, protominid, moxifloxacin, pyrazinamide. And this actually showed a significant increase both for the sputum conversion in fully sensitive disease compared to the standard regimen, but also in those patients, they had a nearly 96 culture negativity at the 8-week mark in the multi-drug resistant TB cohort, which is reassuring because at the same time with this trial, this is the one that set a lot of the momentum for protominid's use and its approval in 2019, is the Nix TB trial that was a phase 3 multi-center open-label single-arm study looking at XDR-TB patients and MDR patients with drug intolerance and failure. And there was 109 patients over 3 centers in South Africa with bedaquiline, protominid, and linezolid of high dose at 1,200 milligrams for 26 weeks. The rationale was these 3 drugs had little established resistance, they each had different mechanisms, and this could lead to a possible of a 3-drug, all-oral, short-course regimen. And I guess the endpoint they're looking at was clinical and bacterial status at 6 months following treatment, and then again at 24 months post-treatment. And so what they found was that there's a significant time to, culture conversion of all groups of less than 6 weeks, and the majority were less than 2 weeks to culture conversion. 90% remained relapse-free or cured at 6 months, and 90% of those that reached 24 months at that time were cured as well. Again, major side effects were peripheral neuropathy, hepatitis, and myelosuppression, but also difficult to tease out which drug was causing that, as the linezolid is known to do that. These rates of success were much higher than previously established for MDR, XDR, TB. So bioavailability, again, absolutely is unclear, but fatty food increases its absorption. It's got a shorter half-life of around 17 hours, and metabolism is through multiple pathways, but a proportion is through the CYP3A4. It is also a substrate for the OAT3 transporter, so drugs such as methotrexate that use this need to be dose-reduced. Efavirenz may reduce protominid levels, and excretion is predominantly in urine, with some in feces. Again, CSF penetration is unclear, and there may be further information after release of a practical PK/PD sub-study of the TB Practical study. Now, as it stands, in the last 18 months, there's an updated MDR treatment recommendations in the 2018 based on available meta-analyses, and in March 2019 there was consolidated guidelines produced by the WHO saying short course of 9 to 12 months with an injectable or an all-oral long course with bedaquiline was endorsed. And then in August 2019, protominid was approved for the BPAL regimen. And now in December of 2019, there was a call out for all available data, and a rapid communication was produced saying that they felt comfortable promoting an all-oral regimen both for short and long courses, with these updated guidelines due to be released sometime in 2020. Sorry, thank you. I don't know how much time is that time?
So you're now the Queensland expert of these 3 drugs, Stefan, so that's great. So that was a very formidable job to cover those 3 drugs, which I thought were important just because we're not used to having options in TB, and now we have some options. Are there any questions at all? So I guess 2 things I'm sort of interested in. One is that, Ben's going to speak soon, but that these, in terms of paediatric TB, obviously, so Delaminid is for what age can we start?
So Delaminid above the age of 3.
And bedaquiline above the age of 6.
Above the age of 6.
And I guess all of them sort of had questionable PK in the CNS, didn't they? For these discrepancies. You often just, not detectable in CSF, but yet in rabbit studies they find the brain tissue. So I guess how we use that in TB meningitis is a bit difficult. And this other comment was just interesting that the protominid was developed by a non-profit organisation. I'm not really sure of any other antibiotics which have been FDA approved which haven't been developed by pharma as such. So it's sort of interesting about this pipeline problem for drugs in antibiotic resistance. This is the New York-based TB. What was it? It was the
TB. Alliance,
TB Alliance, big part, and so they were able to develop that. So that's sort of interesting, maybe just in broad terms, how we go about funding these new antibiotics. So if there's no more, thanks very much for time. So I asked Baton to cover that ground, partly to introduce our next speaker, Philip de Croo. So When we chose to have this meeting, obviously we're a UQ-based, Queensland-based group having an away game here in Melbourne, organising this meeting and associated with ASA, but it was really great to take advantage of the local expertise here in Melbourne in tuberculosis and global health, obviously, and there's many institutions here which are leaders locally and internationally. And so I'd like to have Philip de Croo here. Philip's is an infectious disease physician. He's worked extensively around the world, including Central Asia and the Stans and Africa. He's worked with NSF. And so Philip's going to talk to us now about some of the progress which the Tons alluded to in short course therapy. Thank you.
So thanks very much. So good news. A couple of the previous speakers have got some similar slides, so hopefully I can catch up a little bit on time. And maybe just to also let you know my conflict of interest, for good and for bad. I was involved in the Practical trial that Mark mentioned in the protocol writing committee and steering committee, and I've also done a consultancy for TB Alliance. And I also note that there are a number of other really clever people who are working on DRTB trials in the audience. So Catherine Berry, you don't escape without being named, and there are some others in the audience as well. So please ask them the questions in the break. I just start with a case of a 40-year-old I saw a while ago with bilateral disease, some cavitary disease, and resistance pattern of all first-line drugs and prothionamide, but sensitive to fluoroquinolones. And just thinking, what treatment regimen would you give, and how long would you give that regimen for? And just keep that in mind as we go through. And what I'm going to cover today in this short time is more a helicopter view. Think of this as, you're in a helicopter flying over Victoria Falls. I'm not going to throw lots of numbers and data. You've had quite a bit of that already. I just want to give you an idea of what the landscape is for all the clinical trials that are ongoing at the moment, because whatever I teach you today, you're not going to walk out as MDR TB experts, although some of you probably already are, but whatever I tell you, the guidelines have just changed, and the evidence for that guidelines is not even yet published to be able to present to you. So it's a difficult time to be doing this particular talk. So with all of those caveats, let's get into the helicopter. So I'm going to start just with an overview of drug-sensitive TB and what are the trials that are ongoing at the moment. And this is my classification, so it's probably not worth very much, but just grouping it into 4 groups. The trials of fluoroquinolone-based regimens, those looking at higher dose rifampicin-based regimens, those looking at sort of completely novel drug-based regimens, and then some alternative strategy trials. So I'll just sort of give a few words on each of those. So there's recently been a Cochrane review that's looked at the shortened, particularly the fluoroquinolone regimens and the 5 trials that are out there versus standard regimen. This is the analysis for the moxifloxacin-based 3 trials, but it's similar for the gadifloxacin and the rifapentine. And essentially, the shorter regimens came up short, and they came up short because of relapse. So the relapse rate was, for moxifloxacin-based regimens, was 3.5 times the risk of relapse compared with the standard of care for 6 months. Now, they actually performed similarly on mortality, on adverse events, and on failure in the other markers that we would be looking at. So I guess one key message is, if we're going to shorten treatment, the biggest thing to direct attention to is, can we keep low relapse rates? So I guess summarising, the key lessons I've learnt from looking at these trials over the last 10 years, and I point you for questions to someone who participated in the Remox trial, Kasha Singh, who's in the audience. What I've learnt is that our sort of early predictive trials, like mouse models, EBA studies, even phase 2 studies, don't predict relapse. And I think secondly, we don't have a good biomarker to predict cure or relapse, so we're using culture conversion, but it's not a great predictor for relapse. But the other conclusion, which is an unusual one, is the majority of patients actually could be treated with shorter regimens. They actually do well. And so we're treating everyone for a longer period to pick out those few who are going to relapse. And that's relevant. Just keep that thought in mind for later. I think after lunch there'll be more data presented around rifampicin, so I'm not going to go in detail, but just to say that there have been some toxicity studies done, and now there is a phase 3 trial looking at higher doses, so both the 1,200 milligrams and the 1,800 milligrams of rifampicin within the standard regimen. And this trial is ongoing with results expected middle of next year. Interestingly, they've excluded participants with HIV. So one of the challenges that we've all seen through the fluoroquinolone studies was that you spend a lot of time and money to get a result to say that the regimen doesn't work. And so some clever people have come up with a novel trial design called a phase 2C trial design, which is essentially a 2B but with longer follow-up, and patients are continued to complete the shorter regimen. And so the idea is that you could actually do more of these studies and get more information quicker than moving straight to phase 3 trials. And the Panacea group, which is a trial group mostly based in Africa, is looking at starting one of these trials soon, looking at 3 novel clinical entities combined with Bedaquiline, and even as of the end of last year, the drug X was yet to be named. And so they're looking at 4-month regimens compared with the standard of care for 6 months. And some of this was mentioned by the previous speaker, so I won't go in detail in this. But I guess, we've still got to tease out with the trials around pretomanid, what is the added value of pretomanid in these regimens, given that they do have bedaquiline, which we know is a very effective drug. And so I think, given the way these combination regimen trials are being done, it can give you an answer about a regimen, but it makes it very hard to compare individual drugs and know what is the best treatment for the patient that's in front of you. I think this is an interesting trial in the strategy section of trials, which is called TRUNCATE TB. And this trial is looking at the idea that although in clinical trials the standard of care has performed very well in drug-sensitive TB, in programs it tends to perform less well with 85% or thereabouts success rates. A reanalysis of previous trials shows that for those treated with the standard of care for 3 to 4 months, the majority of patients are actually cured. And again, this idea that because of higher relapse rates, we're treating all patients for longer than maybe some patients would need. And so the concept for this trial is, can we treat all patients for less, and those patients who relapse we then treat for 6 months, so that maybe 70 or 80% of patients would get 2 months treatment and the rest would then get 6 months of treatment. And they're using what's called a multi-arm, multi-stage trial design. So these are preset analysis points with multiple novel regimens tested, and at these interim points, based on pre-specified criteria, they can stop or continue arms, and they do this multiple times until they get to the end of the trial. There's 4 different novel regimens, including new drugs such as linezolid, clofazimine, 35 milligrams per kilogram of rifampicin, and also bedaquiline and rifapentine, each in 1 arm. So with this particular strategy, they're actually following up for 2 years and seeing whether those treated with this strategy of 2 months and treating those who relapse for longer does better than all patients being treated with standard of care for 6 months. And completion of this study is expected mid-2022. So now moving for the rest of the talk, looking at drug-resistant TB treatment. I'll just kind of summarise. The reason I got interested in this is if you actually look at our overall data, you can see that nearly 500,000 new cases of drug-resistant TB, of rifampicin-resistant TB, are predicted to occur each year. Now, if we look at how many of those cases do we actually get to relapse-free cure, we're less than 20%. So we're failing miserably globally on this epidemic. And we have a long way to go, and at every step of this cascade, there are massive problems. But one of the key problems is, in addition to the trouble with the diagnostics, is actually having an effective regimen that you can scale up. We've heard about the change in WHO guidelines in 2018, and one of the key things that we've seen is that the drugs such as injectables that we've been using for years and making patients go deaf and causing a number of other problems have now mostly dropped off this chart completely. So kanamycin and capreomycin are no longer advised for patients. Capreomycin's been shown to actually be harmful for patients. Amikacin still stays on the list, but only to be used for selected patients. And it's actually recommended that all patients should be considered for bedaquiline and linezolid and a fluoroquinolone within their regimen. So a massive change. And all of this is actually really essentially based mostly on cohort studies and not on the clinical trials. Most of the clinical trials, by the time they come out, the standard of care has already changed, and they're too slow to give us the answers we need to face the scale of the epidemic. So the other thing I wanted to highlight in the guidelines from 2018 is it did talk about this shorter regimen with an injectable, which is now no longer a preferred regimen. But it also talked about this option of doing operational research, and there are many countries that have started shorter regimens with 4 or 5 drugs for 9 months or thereabouts in several countries. So I'm on a DSMB for a study in Afghanistan. There's a study that's starting up in Mozambique. We're just working on a protocol for one in Papua New Guinea as well, and that's just off the top of my head. There's probably 4 or 5 others out there. And the recent guidelines change, I think, is of interest. There's a few things that we probably already knew had the evidence to do, and most of that comes much more from the cohort studies, that it's safe to use bedaquiline for longer than 6 months. It's safe to use bedaquiline and delaminid in combination with good monitoring. But what they've recommended now is essentially using the shorter regimen from Bangladesh with taking the injectable out and replacing it with bedaquiline. And that's hidden in this subtext in this rapid communication. We'll see more of the data and the more detailed recommendations come out later this year. But of interest, the regimen that it's recommending is not the regimen that South Africa is actually using at massive scale. So in South Africa, most people who get MDR-TB are treated with a 6-drug regimen or a 7-drug regimen that has linezolid for 2 months, so to shorten the duration of linezolid to be able to reduce the risk of side effects, has bedaquiline throughout, and a number of other drugs to make up the regimen for around 9 to 11 months. So moving to the drug-resistant TB trial landscape, and I'll just use this picture. This is one of the first patients in South Africa who just completed treatment with XDR with bedaquiline. And it's just always worth remembering that patients are at the forefront of what we're talking about. She went completely deaf and had to self-fundraise to get hearing cochlear implants because of the best international gold standard treatment of the time. And so we really need to move quicker if we're actually going to respond to our patients' needs. The pipeline, this talk 10 years ago would have been a much shorter talk, but we've got a healthier pipeline, and the different colours shows different classes of drugs. And when you start to see a pipeline that has different classes, you start to have the possibility of completely novel regimens, which means this idea of rifampicin-resistant TB may become a definition which we can completely move away from. We might be able to have pan-TB regimens. I'm not going to go into these in detail. There are a lot of early phase 1, phase 2 studies underway. I'm going to focus more on the phase 2, 3 end of the pipeline area. A colleague and myself sort of put this pictorial together just to kind of show that there are a number of trials out there looking at sort of, with their primary objectives, different aspects of the MDR-TB landscape. And so there's a number of trials looking at treatment shortening. But for those clinicians who have pitched themselves to focus on other bits, as the guidelines have changed, that is a completely frustrating thing to do when you're mid-trial and your comparison arm is the WHO-approved standard of care, and WHO keeps changing that. It's going to make it really hard to interpret a number of these trials. We heard from the previous speaker around the STREAM trial, and I think it's interesting looking at the findings. This is a trial that took 10 years, and it showed that non-inferiority for a regimen, and by the time it came out, the guidelines had changed. And it has done really well, but the regimen that it was comparing to is now an outdated regimen that we would not want to give to any patient. It went on to have a stage 2, which results will come out sort of next year. But interestingly, because injectables are no longer recommended with new evidence, then regimen D automatically falls off our list as anything to be particularly interested in. And regimen C is now already very similar to what WHO is advising. So I think being in clinical trials, at least for the last 10 years in MDR-TB, has been incredibly difficult. Now that we're getting a shortened regimen being advised, if we use that for new trials as the standard of care, we'll be able to get trials completed probably a third of the time, in 2/3 of the time that it used to take, and maybe greatly reduce the cost. The trial I was involved in was at least 25 million Australian dollars. So they're quite expensive undertakings. We've heard about the Nix trial and the high success rates that have been reported. I guess what hasn't been talked about too much is that there are 2 relapses. I think the second point that's interesting is in trials like including Bedaquiline that has really long half-life, so that there's still measurable drug in 5 or 6 months, using a 6-month primary endpoint to measure your relapse outcomes, whether that is the appropriate time point. And I don't think we actually have the data yet to say with regimens containing clofazimine and Bedaquiline, when is the optimal time to be looking for relapse. So just keep that in mind when you see these great results coming for trials. I guess the other thing to say, I'll skip the slide. So I was going to say it's a single-arm study. There was no comparison group, and it was only done in South Africa. And the amount of monitoring required for these patients, many of them had to stop and start linezolid multiple times with really intense ophthalmology monitoring. And that's something that we could do in Australia if using the Nix regimen, but I think would be really super difficult in many of the places where I work, such as Papua New Guinea. There is this optimisation trial looking particularly at the linezolid dosing, which will come out next year to hopefully answer that, looking at 600 milligrams daily, or based on mouse models, looking at 1,200 milligrams 3 times a week, which is thought to sort of balance out the adverse events versus the efficacy. You'll be happy to know I'm not going to go through all of these trials. I just wanted to put up there that there is a large number of novel short regimens of 6 to 9 month duration that are all oral that are going to come out in the next 1 to 2 years. I don't know which of these is going to perform the best. They're certainly going to perform better than what most countries have been giving patients in the last sort of decade. But I think it's an exciting time, and when you've got a pipeline as healthy as this, then there's very likely to be at least one winner, if not more than one winner, in terms of what regimens we're going to be using in 2 years' time. And maybe just a couple of words on strategies, because we're always thinking about the new drugs and the regimens, but maybe we're also missing a trick, because maybe some of what's happening with TB, drug-resistant TB, is about the damage that's done in the body, and maybe using host-directed therapies may also be a strategy that helps us shorten regimens. So there are a number of groups, but they're much more in early stage trial designs, looking at some of these particular agents to try and see if they can prevent emergence of resistance or accelerate eradication of infection or prevent permanent lung damage. And then finally, most trials have taken the approach of the one ring to rule them all. Let's try and have one regimen that we give for an exact duration, but maybe we need to change our thinking, and maybe we can use particular predictors from patients to determine which patients get a shorter regimen and which get a longer regimen. And so this is a strategy trial that will be also using a MAMS design, looking at whether patients have cavitary disease or not, and whether they have a higher mycobacterial load or not, as measured by smear, to determine duration anywhere between sort of 6 to 12 months. And so In summary, where are we at the moment after that whirlwind? Well, the current drug-susceptible TB treatment remains the same, but maybe there's hope for some improvements over the coming 5 years. And for rifampicin-resistant TB, all oral regimens for 4 to 5, with 4 to 5 drugs. Certainly for many patients with worse prognostic features, you might want to go longer for 18 to 20 months, but for particular patients, you may think about shorter regimens of 6 to 9 months, and we'll see when all of that evidence is released in the next 2 to 3 months. So, thank you very much.
Well, thanks very much, Philip. That was excellent. Any questions for Philip?
Question about the bedaquiline with its long persistence. Do you see bedaquiline resistance in relapses after that, but effectively had a period of monotherapy?
So in most of the places where I work, we can't get the resistance testing, so we assume resistance and we don't know. I think there's certainly been quite a few reports of bedaquiline resistance, most of it in patients who are failing treatment. There have been some reports in relapses, but I don't have any data to say how common that is.
I feel no question about linezolid. So longer courses and hematological toxicity, how big a problem is it in those trials?
Yeah, so the hematological toxicity tends to occur earlier than the peripheral neuropathy and the optic neuropathy. So for most of those trials, for the Nix trial, hematological toxicity was reasonably common. So I don't remember the exact percentage off the top of my head, but basically at least 70% of patients had to have an interruption of linezolid. So that gives you an idea of how much juggling around with the hematology and the peripheral neuropathy. They didn't see much optic neuropathy, which is a bit different to some other countries' experience. And there's a question around whether there's going to be difference in different populations.
Okay, well, thanks very much, Philip.
Thanks.
So our last speaker of this session, and it's been a shame to have to get 4 speakers in the session and have a little bit less time, because it's all been great talks, but I'd like to have Professor Ben Murray. So Ben's originally from South Africa, now lives in Australia at the Sydney, at the Children's Hospital at Westmead, I should say, Professor of Paediatrics at the University of Sydney, and Ben's he's on the NTAC, National TB Advisory Committee, and is very well regarded in his expertise in paediatric TB, and I know my paediatric ID colleagues in Queensland often give Ben an email for difficult TB questions. So thanks very much, Ben. Thank you.
So thank you, Andrew, for having me, and I must admit I'm going to spend a bit of time today just first talking more broadly about mycobacteria because I think there's a lot of relevance given the diversity of talks that we have today, and towards the end focus on childhood tuberculosis, and hopefully if there's questions be able to answer some of them. But just focusing on mycobacteria as to link in with the broader theme of the conference, I wanted to touch on some of the genomic work that we've recently done that may be of interest to the group. So for a long time we've thought, and gyrA Diamond and others have said with confidence, that MTB is essentially a zoonotic disease. It originated in cows, probably evolved from M. bovis, and humans acquired it during the transition where we started farming. But the first genomic evidence really that Roland Broch produced in 2007 suggested that this is not true, and that most animal strains that we find today seem to originate from ancestral human strains. This has been followed up by further work from Sebastian Ganot's group, where they did detailed whole genome sequencing and typing of strains found all across the world, and reconstructed the likely origin of MTB, which is very clear to have originated from Africa, which is where we get the greatest strain diversity. And essentially, the main lineages we find around the world traveled with human migration. And obviously, this picture has been mixed up with all the human population movement and colonization that happened after our original dispersal from Africa. But this is still the most likely picture we have of TB's origin and spread. Why TB is mainly found in humans remains an open question, but James Trower is here, but was involved in a study that really interrogated what is it that's different in the human species. And the main difference is the fact that we are the only species on the planet that have ever controlled fire, and that exposure to very dense indoor air pollution, which is the way our cave-dwelling ancestors lived in a lion-roaring Africa savanna, probably opened up an environmental niche for TB to spread as a respiratory pathogen. And I think this still remains a very interesting thesis and may represent the first example of humans being the victim of our own manipulation of the environment. And whether take that as climate change or not, but it's clearly an example of how manipulation of our environment can put us at harm. Sebastian has looked at greater detail more recently at the origin of animal strains and looking again at all available collections that they have at the Swiss Tropical Institute of Human and Animal Strains. And this picture was recently published, and this is fascinating because it replicates what has been shown before, but it shows that most animal strains, or all the animal strains, very likely originated from lineage 6, which is mostly found only in Africa at this point in time. There's this interesting seal mycobacteria, which has been found in Peruvian mummies, and it's always been a debate, how did TB arrive in South America pre-colonization? It seems very likely that M. pinnipedi may have been spread to Peru by seals, and there was a recent example of a vet in Western Australia that developed TB disease from M. pinnipedi after treating a diseased seal. Just as an example, and we're not sure what the ancient populations in South America did, but there is every chance that they may have hunted seals and had close interaction with seals during the butchery. So that's always remained a bit of a dark horse. How did the M. pinnipedi end up in South America? We now have a likely explanation that it may have had a seal origin. Another fascinating observation is that M. oryx, which we always thought is an oryx, it was first described in oryx in a zoo in Amsterdam, and given the name oryx as if it's an oryx pathogen. People have now looked at what is the cause of bovine TB in India, and have essentially found no M. bovis. And most of what they find in cows in India is either cow-adapted human strains or M. oryx. And M. oryx seems to be particularly adapted to Bos taurus, which is the Indian cattle variant, while M. bovis seems to have adapted to human cattle, which is Bos taurus. So we are starting to understand the dynamics of this organism a bit more. Within our group, one of our bioinformaticians wanted to have a deep look at mycobacteria in general, and really looked at all the sequences that were available in GenBank of high-quality sequences, around 160 at the time, because there has been a big debate about rapid and slow growth. If you reconstruct the phylogenetic tree, and I think this is the most complete phylogenetic tree that's ever been constructed, looking at more than 300 core genes to construct this, and showing, first of all, that you get some slow growers, the red ones, that are intermixed with rapid growers. But what is very clear is that rapid growers, including M. abscessus, seem ancestral, that there was a very clear, essentially single transition from the rapid to a slow-growing phenotype. And you can see beyond that branch point, all of these are slow growers. So a big question is, what happened at this branch point, which preceded the taming of the control of fire. You can see here the blossoming of M. tuberculosis complex, and over there the Mycobacterium intracellulare and other related species. So delving a bit deeper and doing comparative genomics, these are some of the signals that have emerged. And here you can see again the phylogenetic tree. There's the transition point between rapid and slow growers. And you can see that there are some operons that are uniquely conserved or found in rapid growers that are lost in all slow growers and probably were lost at the time of that transition. So most of these operons are related to metabolism of amino acids and other substrates, which may be important if you want to live in the soil, but not important if you adopt a more pathogenic lifestyle. Another interesting observation on the right here, again, the phylogenetic tree. The red and green is just a heat map showing protein similarity of the MCE gene, which is the mammalian cell entry gene. This gene was considered to be essential for TB to enter the macrophage. Using MTB as the reference, you can see that all MTB complex strains have very similar MCE genes, and they are highly duplicated. There's essentially 5 copies. But MCE is not unique to MTB complex. It's found throughout mycobacteria. And this MCE gene probably allowed entry into amoeba in the environment for mycobacteria eons ago, and you can even find it in rapid growth. So there's a lot left to be understood. It's not as simple as these MCE genes give only entry to the pathogens. Clearly, the pathogens have refined this mechanism, but the mechanism has been evolutionarily available. All right, so that's just some of the, I suppose, interesting work which needs to be followed up around what does, or what do we now understand about that evolutionary transition. So moving on to BCG, which obviously was evolved from M. bovis. The evidence that we have at the moment is at least that BCG offers reasonable protection against disseminated forms of disease for young children. We don't have good evidence that it protects against adult types of disease. There's very conflicting evidence that in nurses, in low incidence settings like Norway, BCG showed great protection against TB in nurses that were skin test negative, but in large trials in India and other places, no protection has been offered. And James is working on a better interpretation of BCG protection as well. But there is consensus that in young kids, there's high-level protection. We also know that during this recent BCG outage or shortage, that there was a spike in TB meningitis cases all around the world where these outages occurred. And Cape Town in South Africa had one of the best exemplars of the rise in cases. Another interesting observation that people haven't been aware of in the past, and we couldn't test really pre-IGRA, was the demonstration that BCG protects against TB infection. And this mechanism is clearly not dependent on the acquired immunity. It seems to be a training of the innate immunity, where BCG vaccinated individuals are less likely to become infected or register a positive IGRA post-TB exposure than unvaccinated individuals. And this data looked at a lot of studies that were done across Europe and showed a fairly convincing signal. Just on the topic of BCG, we get frustrated with the drug developers and the trialists. Why do drugs take so long to get into clinical practice? People get even more frustrated with the vaccine guys and say, why don't we have a new vaccine against the world's biggest infectious disease killer? This is just, I suppose, a reminder of the unique features of TB and the challenges that a vaccine development poses, where for most vaccine preventable diseases, measles, smallpox, we essentially have very low levels of herd immunity in the population. Following vaccination or large disease outbreak, you get a dramatic increase in the level of immunity in the population. You essentially establish herd immunity, and you don't get transmission of measles or smallpox anymore. TB, the starting point is completely different. The rate of disease development in someone infected with TB is less than 10%. And in someone who's malnourished and living in affluent environment like us, it's probably less than 5%. So we essentially have high levels of natural herd immunity against TB in the optimal human condition. What is very important are those factors that detract from immunity at a community level. The malnutrition, the crowding, the stress, and we know this from all the war and poverty research that's been done. So it's really those factors that reduce the level of herd immunity at the community level that we need to consider as well. Obviously, if you can have a vaccine that maintains high levels of herd immunity, that would be great, but just to remember that the starting point is completely different. So just what else do we know about BCG? BCG is currently, again, a hot topic of discussion. So we know it protects against leprosy, and that's probably its biggest value in places like the Pacific. We know it offers some protection against NTM disease. There's not only mouse data, but there's also good data from places like Finland, where BCG was discontinued, and they saw a very clear rise in NTM infections in the cervical nodes. The big question is, what are the cross-species protection that BCG offers? We know that BCG offers good protection against M. bovis, and vets in New Zealand have been vaccinating cows for quite a while to protect them against M. bovis with reasonable efficacy. But what protection does BCG offer against M. abscessus or against other pathogenic species? We know that BCG is a very low-risk vaccine, so there's really no downside for giving it a try, and we know that it essentially exposes your immune system to a wide array of antigens that are expressed by many other mycobacteria. All right, so on the BCG topic, I suppose a big discussion in pediatric circles has been the original documentation by Peter Abi's group in Guinea-Bissau that BCG reduces all-cause mortality, not only TB-related mortality. This was initially not regarded as with a lot of seriousness, but WHO asked a special advisory group to advise on this, and they concluded in 2015 that they believe this is a real phenomenon, that all the data that's available backs this. The big question is, what does this mean for new vaccines? Would we expect a BCG replacement vaccine to also offer all-cause mortality benefit? And then lastly, I think the big appreciation that there's a lot that we don't know about BCG, that BCG was a live vaccine distributed through labs throughout the world, and it evolved before it became lyophilized. There's no one BCG vaccine. There's a whole host of strains. We don't know really which are the ones that offer best protection. We also don't know which are the best routes of BCG administration. There was a recent publication in Nature that has shown that intravenous administration of BCG offers greatly enhanced protection against disseminated forms of TB disease. We also know there's a number of new studies looking at inhaled BCG as the preferred method of delivery, apart from intradermal delivery, subdermal. So moving on to childhood TB, just quickly, children get TB where adults spread the disease. So for a long time, this was used as a way of saying kids are not important. Let's just treat the adults and child TB will disappear, which is true from a strict epidemiological sense, but reality is there's lots of kids with TB out there that are treatable, easily treatable, and it's a top 10 cause of under 5 mortality. Why is it that we see different disease burdens in different settings? And people working in a setting like Australia may say child TB is not a big problem. So I think this graph illustrates it best, that we know in settings like Australia where disease rates are low, 10 per 100,000 or lower, and we've got a very mature population pyramid. There's a low number of kids out in the community. There's few infectious TB cases, so TB doesn't rain down on kids frequently. Kids are malnourished and disease rates are low, less than 5% of all TB cases. But if you go to a place like Papua New Guinea, where disease rates are 1% of the population, 1,000 per 100,000, the population pyramid is very flat. There's lots of kids. We know that more than 50% of hospital admissions in children are related to TB, whether that's an accurate diagnosis or not, but there's a very high disease burden. So it's very setting-specific. We also know from old natural history of disease studies that the disease burden across the age is not constant, that young kids are extremely vulnerable, especially in this first 2-year period when their T-cell immunity is immature. and that as kids enter into adolescence, there's a sudden increase in TB risk again, but at the same time of the increase in risk, there's a complete phenotype shift where these kids now develop cavity disease. And maybe just to show, TB in children is not like adult TB where there's mostly apical nodes that are involved and you're looking for cavities. There's a whole host of manifestations in TB. A common manifestation that we see in very young kids under 3 months of age or under 6 months is that they develop lobar pneumonia. And if this kid dies, this child will be recorded as pneumonia death. But it's only on autopsy that you can establish that this is TB. We often say kids don't get cavities, which is generally true, but we know there are different mechanisms of cavity formation. This is a 2-month-old child that developed a cavity at the point of entry of the TB into the lung. We call this a complicated gone focus. And this essentially is an inability to contain the organism at the point of entry. While this child developed an expansile pneumonia, you can see complete compression of those airways. This is caseating pneumonia secondary to airway obstruction with areas of breakdown. But this is essentially due to the caseating process and the absence of drainage of that caseating mass, which we also see in young children. And then you get the cavities that we typically see in adults that we know has got a very strong immune component and that contributes to the parenchymal destruction. So where do we stand with childhood TB? Just the latest data is that there's more than 1 million children that develop TB every year. TB is now recognized as a top 10 cause of death in children under 5 in TB endemic countries, although you won't read it in any stats, because it's not reported as a TB death in most instances. A big problem and something that the groups in Melbourne are looking into, Catherine is looking at TB in adolescents, where we've got a poor handle on the disease burden because WHO age categories only report kids older than 15 to 25, so we can't really get a handle on the adolescent disease burden. In childhood TB, these are the current gaps, and you can see the biggest gap is the estimated gap in case detection in kids under 5. These are the kids who stand to benefit most from prevention therapy, but you can see less than a quarter, really, of kids globally are able to access preventive therapy following TB exposure, household exposure. This just shows it in a different way and showing that there's steady but very slow improvement, I think. So I think this has for a long time not really registered on the radar screen of researchers. There are now a number of studies looking at how can we truly increase the access of children to preventive therapy in TB endemic settings. The reality is that in most TB programs, if you ask where's your TB prevention budget, there's no budget. There's no tool to develop a budget line for TB prevention. It's never been emphasized by the programs. It's not measured. And if you don't measure something, there's no incentive to deliver on that. So there are a big focus on how can we improve delivery to these vulnerable young kids. Another big question, and I'm sure Justin will allude to this after lunch, is how do we deal with a big pool of latent infection? And I just wanted to show these 2 slides which are provocative and not easy to interpret, but I think it's good for us to keep in the back of our minds if we consider the individual and the population benefits of LTBI treatment. So this was published by Marcel Baer, and this is a collation of data from Shirley Therapy, who worked with Comstock, that essentially showed that if you provide INH preventive therapy to household contacts and you follow them over time, you can see that the INH has got major benefit, but in the first 2 years following exposure. The long-term benefit of INH versus placebo is minimal, in this study at least. And another way of, I suppose, reinterpreting what should we do with a positive skin test, does it imply latent TB infection or does it reflect just TB reactivity, is this interesting study which was done in asylums in the US back in the 1950s, 60s. But it essentially showed if someone had newly converted TST and you treated them within 3 months, they reverted their TST in the majority of fairly quickly. But if they stayed positive for a long period of time, the duration of reversion and the percentage of reversion was greatly decreased. So showing that this TB reactivity is influenced by the rapidity with which you institute preventive therapy. So even in these cases that you would assume were fully treated, they remain skin test positive. And another interesting piece of data is looking at people who start infliximab treatment who are skin test positive. We all know that people are vulnerable if they go onto TNF-alpha blockers. But if you look at all the cases that develop TB, that were skin test positive after infliximab start, only about 5% of them develop TB, and nearly all of them develop TB within the first 12 months. So how do we identify that 5 or 10% of reactive people who can benefit most from preventive therapy? Should we apply a person-centered approach or a population-centered approach where we know from the Inuit data that if you treat everyone with latent infection, you can reduce the TB burden, even if the individual benefit may be limited? So lastly, just to touch on MDR-TB, we know that for a long time people have said children don't get MDR-TB because MDR-TB is unlikely to be transmitted. We know that's not true. This map shows you that wherever there's been an adult case of MDR-TB, there's been pediatric cases documented demonstrating transmission. And if we look at a world map of where children get TB, MDR-TB, this is what the current best disease burden estimates are. The reality is that MDR-TB adults have got poor access to treatment, but kids have got even worse. Most countries don't even offer MDR treatment to kids because they require culture confirmation. And if your mum dies of MDR-TB and you are diagnosed with TB, you won't be put on TB treatment if they can't confirm the MDR-TB in you. So WHO, as part of their new guidance, have instituted a category of presumptive MDR-TB for children to encourage MDR treatment of young children. And there are now child-friendly MDR treatment drugs available. So lastly, just to say there's an ongoing, I suppose, effort for child and adolescent TB to stay on the map, even though we need to break transmission to break this, the epidemic. We can protect children, we can reduce mortality in children, and there are a few important things that we can be doing better, such as preventive therapy and access to care.
Thanks, Ben. That's terrific. Any questions for Ben?
You covered a lot of material. That was a great presentation. About the reference to BCG, it sounds like BCG is not all created equal. What's the version we use in Australia? And is there potentially better or worse versions of BCG?
Yes, so there are people who feel very strongly about that there definitely are versions that are potentially better than others. WHO normally source globally on the best available supplier. And Chris may be able to back me up about the current strains, but we used to have the Danish strain available when that was still provided originally by Sanofi and later on by Start and Serum Institute. The Connaught with Sanofi and then the Danish with SSI. SSI withdrew from the market for a while, and we then got a strain from Poland, which was used, which is a Russian strain. All of them have got different deletions. They have different immunogenic effects. But at least what we can say globally is the places where we've seen spikes in TB meningitis and severe disease in kids is where there was BCG discontinuation. There aren't very clear differences in the global distribution of disease burden according to strain use. But in Australia at the moment, we have got access to the Danish strain again, which is a reactogenic strain which most people believe offer probably amongst the best protection.
Any other questions for Ben? Well, if not, thanks to Ben and all our speakers. I'm sure they'll be happy to answer questions at the break. So thanks for making up time, those speakers as well. That's terrific. So we'll try and stick to our plan and break for lunch and come back at 1:30. So thanks very much. Thanks, Ben.